Fellowship under Dr. Cloesy. Adam also has a very impressive attending-like track record of publications, and from Florida, Minnesota, and Missouri. We checked him out, and he also got rave reviews from every place he's been. And so we are also really excited to have him. Jason's going to be primarily at the university. Adam is going to be primarily doing his total joint practice at Northwest Hospital. So welcome, Adam. I think you'll get to see that they are in some ways quite different, but they are both hugely talented and hugely ambitious. So we are expecting great things from them. A couple of other announcements. Some of our residents have received very nice comments from some of the attendings and nurses that they've interacted with. And here is one for Stuart Michnick, which is from the Adult Medicine Clinic, Renata Bronson. And dear Dr. Hanel, I am medicine attending at Harborview and wanted to let you know that I worked with Dr. Michnick today and I was very impressed with him. He answered the consult pager promptly and guided me through the initial steps for caring for a patient with a humeral shaft fracture who showed up at the Adult Medicine Clinic following an accident in Missoula. He later came to our clinic to assess her and he was very patient, responsive, and thorough. He was lovely with the patient. He was efficient and professional. He spent a good portion of the morning helping us, and it was clear he was managing a lot of other things simultaneously. So I don't know if Stuart is here, but thank you. There he is. Here is a comment from Sue Tyler. Hi, Howard. We were eating lunch today, and many RNs and assistive personnel had rave reviews for Alan Swenson. They stated he is the best ortho resident ever. It's going to be tough to top that for the next 3 years. He calls back, is patient, personable, helpful, and checks in. In addition, staff said he asks how they are doing. One day he was happy to take care of a patient when that resident couldn't be there. Please pass this along and thank him for us. So thank you, Alan. And then finally, Alex Lauder. Is Alex here? Alex got a note from Fiona Gallagher, who's the program director for the emergency medicine residency at the UWMC. And this says, congratulations, Alex. You were selected as the 2014 Outstanding Consultant of the Year by the Emergency Medicine Residents and Faculty. Thank you for leading the emergency medicine residents by example on how to be an outstanding consultant. Your professionalism and clinical excellence are appreciated. The residents and faculty look forward to working with and learning from you in the future. Thank you again for all of your efforts, your dedication and commitment to excellence are appreciated. So thank you. Good to go. Oh, yeah.
Good morning. Thank you for your attendance this morning, and we're very privileged and honoured to have two internationally renowned speakers who've taken the time to spend the times in Seattle since Saturday, actually, when they arrived, enjoying some of our perfect weather, which apparently isn't what they described the weather in Seattle as being like when they came from Norway, but I tell them it's like this all the time. And they've been spending time educating the physical therapists, the athletic trainers, the residents, and the general sports medicine community at the Garrick lecture last night. So Lars and Grethe, thank you for coming, and they're becoming like friends to everyone. They see them around the place. So we'll get to their presentations a little later this morning, but we're going to start with a talk from Sean Halomen about the risk factors that have been discovered for anterior cruciate ligament injury with some of the biomechanical features of that. Now we just need to get the screen to work. As yours here, Sean. This one. Can we turn the lights down a little? There we go.
All right. Good morning, everyone, and thank you, Dr. Twaddle. It's my distinct honor today to be giving the introduction to today's grand rounds with our visiting guest professors. We'll be talking about preventing ACL injuries and the programs to do so. I've been tasked today with briefly introducing ACL injuries, reviewing the current literature regarding jumping and landing patterns on the risk of ACL injury, and trying to ascertain whether or not we can accurately predict risk in athletes for ACL injury. So briefly, there are roughly 200,000 ACL injuries in the United States every year. It's more common in females, and in fact about 1 in 100 high school female athletes will sustain an ACL injury, and that number goes up at the collegiate level. Over half of those will get reconstructed at a significant cost to both the patient and the healthcare system. You can broadly categorize these as contact or non-contact ACL injuries. And contact injuries typically occur with a lateral blow to the knee with the foot planted, as can be famously seen here when Adrian Peterson sustained his season-ending injury. But more commonly, ACL injuries are via a non-contact mechanism like this one with RG3. Now it's interesting that I use two high-profile male athletes because it's significantly more common in female athletes. So I think to accurately represent that, I should put something more like this up. In order to understand how to prevent an ACL injury, it's good to know what the exact mechanism of the ACL injury is. And to do so, we'll first go to cadaveric study. This was a nice study by Markev et al. In the mid-1990s where they looked at cadaveric lower extremities and implanted load cells in the ACL. They then applied a constant anterior tibial strain and then combined that with either flexion extension, internal and external rotation torques, or varus or valgus moments. And what they found was that the highest ACL strain occurred from 0 to 30 degrees of knee flexion, and that increased dramatically with the addition of internal rotation and increased further with the addition of a valgus stress. Another way to try to identify how an ACL injury occurs is through video analysis, and our colleagues here from Norway did this through a novel approach using model-based imaging, and they created a skeleton using camera views to ascertain the joint position at the time of ACL injury. And what they found were that the kinematics were relatively consistent, that the athlete would typically land in relative extension and then rapidly would flex 40 milliseconds later. In the coronal plane, they'd be near neutral and then would have a valgus of 12 degrees about 40 milliseconds later. And then the tibia was initially in external rotation just prior to initial contact, internally rotated, and then had a rebound external rotation. And then lastly, we can look at imaging modalities to help us identify exactly how the mechanism of injury occurs. And this is a standard T2 MRI showing the pathognomonic kissing lesion of an ACL injury with a bone bruise on the middle of the lateral femoral condyle and the posterior lateral aspect of the tibial plateau. And what this study with Viscontas showed was that bone bruises do primarily occur in the lateral compartment, indicating that primarily a lateral compressive force with valgus and internal rotation would be the mechanism of injury for an ACL rupture. So if you were going to design an athlete that was going to injure their ACL in a landing position, then what would you look for? Well, in the coronal plane, you'd look for knee valgus or abduction and hip adduction, which would accentuate that valgus. In the sagittal plane, they would land in relative hip extension and knee extension, which would increase the ground reactive force and anterior shear force, respectively. And in the transverse plane, they would land with tibial internal rotation and it would look something like this. So that's a great theory, but are we able to support that with literature? So we'll go through the phases of landing, and we'll start with the flight phase, which Jonathan Chappell did in this study, where he compared recreational athletes doing a 2 to 3 step run approach, landing with 2 feet and then taking off with 2 feet. And they used reflective markers on the joints to identify the joint position during flight. And what they found was that females typically would have less flexion at the knee as they approached landing and would land with less knee flexion. They would have slight internal rotation of the knee throughout the flight phase, and they would have no difference in varus or valgus. At the hip, again, they would land in relative hip extension. They would have internal rotation and have hip adduction. What happens when you initially make contact and what moments are acting upon those joints? Well, this study was done by Bing Yu, looking at recreational athletes again with a similar task. And what they found were that the hip was relatively extended at landing and they had less angular velocity of hip flexion. The knee was relatively extended when landing, and maybe more importantly, the knee angle when there was the most proximal tibial shear force was less than males. So if you remember the cadaveric study, if the knee is in more extension, then there's higher ACL strain with anterior tibial force. And then overall, they had greater anterior tibial force as well. And then what happens in the coronal plane throughout landing? This was done by Ford, and they looked at basketball players at the high school level and found that throughout the landing phase, females tended to land with greater total valgus, both at initial contact and through peak contact. They also had significant difference between dominant and non-dominant sides. And then what if you can find a sport where the risk of ACL injury is the same between sexes? And Carlo Orochimo found that in professional dancers. And not only do the males and females have the same risk of ACL injury, but it's lower compared to their team sport counterparts. So they did a study comparing 40 professional dancers and 40 team sport collegiate athletes and had them do a single leg drop test. And what they found was pretty interesting. And if you look at the red line, that's a female team athlete, and they tend to land in relative knee valgus or abduction, and that increases through the landing phase. But that female dancers, as indicated by the green line, did not land with any valgus as compared to the male athlete counterparts. The male and female dancers also land with less trunk lean as compared to the team sport athletes. And so they discussed why these differences might occur, and one of them is that female dancers go through extensive landing and jumping training throughout their life, from the start of trying to learn the aesthetics of body position and control their body at all times. But they also are typically smaller than a team sport athlete, and they also always know where they're going to land. Everything is very well choreographed, whereas team sport athletes have the unpredictability of ball motion and opponent motion. So then lastly, what happens when you look at females that injure their knee versus females that don't injure their knee? And this was done by Timothy Hewitt in a prospective manner. He screened 205 female athletes using 3D markers and a drop vertical jump test, and then followed them through 3 athletic seasons and found 9 ACL injuries. When he compared those athletes that had ACL injury to those that did not, those athletes tended to land in greater abduction at initial contact and carried that out through the peak contact phase. They also had greater peak external moments of abduction, and they felt like that knee abduction was a predictor of ACL injury. But what if you look at all studies? Those were nicely highlighting what we thought would be the risk factor for an ACL injury just based on high ACL strain levels. But if you look at all the studies that compare males and females, which was recently done, then what you find is not as clear. And when they looked at the sagittal plane knee flexion at initial contact, if you look at the bottom, only 20% of the studies were able to show a difference between males and females. In the coronal plane, at initial contact, when we think the risk of ACL injury is at the highest, only 36% of the studies were able to show a difference. And the only thing that was relatively consistent was that at peak contact, 71% of the studies were able to show that females tended to land with more valgus and have a higher moment of valgus. In the axial plane, again, unable to really show a difference between males and females. Part of the reason might be that those 31 studies that they reviewed were pretty heterogeneous. They had different populations. They had different landing tasks with double versus single or a combination thereof. And they jumped from different heights. And then lastly, we'll briefly touch on whether or not an ACL injury can be reliably predicted. There are a couple of screening tools that have been researched. The first one by Myers, and this is the probability of a high knee abduction moment. And the University of Vermont team looked at this tool and retrospectively reviewed nearly 2,000 of their female athlete videos and tried to see if they could predict who would get an ACL injury based on this tool, and they were unable to do so. They also looked at the landing error scoring system, another one that's popular out of North Carolina, and this time they added in male athletes retrospectively with a total of near 3,000, and again were unable to predict athletes who were able or who would go on to get an ACL injury. So in review, what we think would be the cause of an ACL injury: knee valgus, hip adduction, and trunk lean, which would accentuate that knee valgus, although this doesn't play out well in the studies if you look at all of them combined. In the sagittal plane, we would worry about landing with knee extension and hip extension, which would increase ground reactional forces and anterior tibial forces respectively, and that's a little more well characterized as far as ground reaction forces, but maybe not in the position of predicted landing. And then lastly, in the axial plane, tibial internal rotation. I think it's a little bit more complex than that. You can't isolate a single abnormality in the landing, and it's probably a combination of all things. That measuring the risk factors is inherently complex. Most people use skin markers, as you can see on this young athlete, and there's inherent error with skin motion. It's easier to use, and you can screen more athletes. Do you use three-dimensional imaging? Do you try to do a model that they did in Norway, which takes a significant amount of time? I think they quoted 1 to 2 months for each video. It's a lot of time. Do you implant a load cell for in vivo ACL strain? I think it's a pretty complex way to figure out who gets an injury. And then lastly, we cannot yet reliably predict who will go on to get an ACL injury, because even the toughest players in the world and the best sport in the world, according to Dr. Twaddle, will end up with an ACL injury from time to time. However, as we heard last night in the Garrick lecture, I think that we can prevent ACL injuries, and I think this is a nice time to segue into Dr. Myklebust's next presentation.
So we know that ACL injury in females in particular occurs a lot more frequently, and if we can identify things that prevent that, that would be useful. Unfortunately, as you've seen, we've got a lot of literature, but it's still a bit of a Bermuda Triangle. We know it happens, but we're not exactly sure why. Grethe Myklebust from University of Oslo in Norway is a academic physical therapist of international renown for trying to help us identify how we can prevent ACL injury in females. Her and Lars have devoted a great deal of time in being very objective and finding ways of assisting athletes in preventing getting injury, and then if they are unfortunate enough to get it, following them carefully so they have extensive data in Norway on what happens to these patients, both with prevention and with injury. And so Grethe is going to talk to us about this development and implementation of an ACL prevention program which they began in Norway. Thank you, Grethe.
Thank you very much, Bruce. Thank you for a very nice presentation. It's a good start for this. Because even though we don't know exactly if we can predict who is getting to get an ACL injury, I think we need to use the knowledge that we have that it's possible to prevent injuries with some types of exercise programs. And we have to use them while we are waiting to really pick out those who are at highest risk. And today I just want to tell you a story about what happened in Norwegian handball. And you probably don't know handball so very well, but it doesn't work. This one? It should? Okay, I can use this one, it's no problem. In Norwegian handball, back in the late 90s, we saw the large sex difference coming up in handball. 5-to-1 females compared to male players. And we didn't like what we saw, and we found out that the consequences of this injury was really bad. Players got out of play, they had a lot of pain, disability, and of course it affected the quality of life. It was a really costly injury for the community, and with a long-term follow-up cost in the future, because of a lot of the players got hugely early away. And the injury mechanisms in handball, you can see very clear here. It's the cutting mechanism, which you see here. I think I need a new one. This doesn't work. And the other one is the landing mechanism, one-leg landing, as you can see on the right. And of course, trying to avoid the one-leg landing, try to land on 2 legs with flexion hip and knees, would maybe avoided this injury that you see here. But this is the 2 main mechanisms in handball, and we see this mechanism also in different sports, basketball, soccer. And this is the way we try to analyze how this happens. The same girl again, doing a cutting movement, and Trond Krosse made this method when you included a skeleton, and which made it more easy to know what really happens when they injure their ACL. I think making this modeling took between 1 and 2 months, the first one, to get every skeleton part into every frame of this film. Really a lot of time. And the consequences of all this knowledge showed us that the players should avoid the knee valgus. And we see the same in many sports, but this is typical for handball. So we thought we needed to try to prevent this injury. And back in 98-99, we followed 950 players for 60 teams in handball. Got the number of ACL injuries and the injury mechanisms. And the 2 following seasons, we introduced prevention programs to see if we managed to reduce the number of injuries. And this program was made by giving the athletes 5 minutes on 3 stations. So the squat was divided in 3, 5 minutes doing exercises on the floor, 5 minutes on a balance mat, and 5 minutes on a wobble board. And each 5 minutes they changed the position. So this program in total lasted for 15 minutes. And the players should do this 2 to 3 times a week in 7-8 weeks in the starting of the season, and then once a week during the season. So 50 minutes is the time that we told them they had to use on this. We also talked a lot about hip control, the knee over toe positioning in all the exercises. Try to keep the hip, knee, toe in line, and use balance, strength, and plyometric exercises. And here you see some of the exercises. Do you have a new battery for this? It's not working. No. Okay. So the cutting movement, we try to focusing on knee control in every movement. And you see some difficult balance exercises, trying to land on 2 feet after a jump, doing throws to each other on 2 legs on a balance board, and on 1 leg, doing squats, as you see there, first on 2 legs, and when you are getting stronger on 1 leg, and all the time focusing on hip control, core control, hip, knee, toe in line. And it was a 5-step program. So we started quite easy and made it more and more difficult. On the left you can see a player doing perturbations, and that really... Yep. And I go back once more, so you see this one. Okay, here you see I can go one more there. And see the jumping exercise on the left, because they often get a perturbation before they land in the play, and that's why we wanted them to get a push, and then they should manage to land on 2 legs anyway. Doing fighting against each other on a wobble board and a balance mat, I think they liked that exercise most. It was easy to make them do it. And of course, doing this launching with the ball with closed eyes on a wobble board is difficult, but it's a good prevention exercise, and of course it's a good rehab exercise. So all of these exercises can be used in the rehab of the athletes. So what happened? This is the control season, and we had 29 ACL injuries at that point. Then it went down to 17 after two seasons, and it was not a significant reduction. The players had a relatively bad compliance, but when we analyzed the elite players, the best players, we found that for those elite players who didn't do this exercise program, they had a 16 times higher risk of getting an ACL injury. So this program worked for those who did it. That's not a bomb maybe, but it's the way it works. So we also, since we tried to reach the non-contact ACL injuries with this training program, then we were happy when we found that it really worked regarding the non-contact injuries, from 18 in the control season down to 17, a statistically significantly reduced number of ACL injuries. So this program worked to reach the non-contact ACL injuries in a good way. So here you see the number of injuries, ACL injuries per team per season on the y-axis, and here you have the seasons on the x-axis. And here is the control season, here are the 2 intervention seasons, and then we have followed them all these years. And now we can see what happened. When we finished the intervention, we withdraw from the teams. It was up to the teams to continue doing this exercise program themselves, but they kept the equipment, so it was possible to just continue doing it. But this was the case 4 years after. It actually went up higher than before, and that was a little bit depressing. Okay, I got my PhD, but it didn't help handball in the long run. So I was not happy with that. So what we did, we had to do something with the implementation. And we made a DVD, and Lars and I went around in the 5 largest cities in Norway and had seminars with the handball coaches, trainers, and told them how important is it, how you should do it, and they all got the DVD with a training program. In addition, this paper came out 1 year after. This is a randomized control trial where we managed to reduce the number of lower extremity injuries among handball girls and boys with 50% by doing a structured warm-up program. So putting these kind of exercises in the warm-up reduced the risk of getting injuries by 50%. And this study got a lot of attention in the media, television, and in the handball magazine, which every player and coach in Norway gets. So, and here you see the knee ligament injuries, the 80% reduction by doing a structured warm-up, 15 to 20 minutes. So, after this major work to try to get this information out, we saw these nice numbers here. A really good reduction in the number of injuries again, getting lower than in the intervention period, which was really good. But we were thinking, could this just be a natural variation? And we found out we needed to follow this even more closely. And then to even more include the knowledge to everyone, we made a website which was launched in May 2008. On this website, all the videos with the program was launched, and it was free for everyone. So we really tried to get this out to them, and it's called Free of Injury, injury free. And we also had one person really working hard to get the implementation out to the clubs, working at our sports center. So here is the website, Skadefri, where you can just point out the knee and you can find exercise program for all of these sports, which are the main sports in Norway. And in addition, in the European Championship in handball, which is all the Norwegian players look at this championship, we had national team players who showed some exercises, preventing exercises that they said, all the young players, you should do this. So in the commercial breaks, we tried to push in some of these video clips, and of course this reached a lot of people, and they are saying some funny things about what happens when you do it right and what happens when you do it wrong, and the good effect on that part. So, so this worked really good. And this is what had happened. Here you see that we have reached a 50% reduction, which has been continued for many seasons. And this is another way of showing it. Here is the number, here is the seasons, and the intervention, it went down, it went up again, and even worse than before. And now we have kept it quite low for several seasons. 50% reduction. And this story is actually told in this British Journal of Sports Medicine issue. We found out the mission is possible. As you see here, we can avoid all these girls getting out with this problem. So if you want to read more about it, you find it there. So why have we succeeded? We can say it's a massive effort, a massive implementation, and it's a lot of follow-ups. When we are doing these studies like this, we have to call the players a lot of times, call the coaches to get the knowledge about injured players, and we have maybe about 7,000 phone calls to reach all these players. And this is my co-worker Arnhild, and she's not so happy that you can see there, because during late nights and evening and weekends she feels like this, because it's a lot of work to reach all these players. So I think we have succeeded because we had personal contact with all the coaches in the teams. We had a website, the DVD. We have courses in the club around the country. We have collaboration with the Norwegian Handball Federation. We have articles in the Handball magazine which reach every coach and player in Norway. And we have regular focus in the media, both television and newspapers. And hopefully we have improved the coach awareness and acceptance of doing this kind of training. So we can prevent ACL injuries, and this is not only for handball. This is just the same for soccer, basketball, volleyball, a lot of sports. So use this knowledge in the sports that you know. And I think make them do a more narrow cut, teach them 2 feet landings, and start early, really early. When they start doing this sport, they should start thinking about this kind of work. And of course, the coach is our main collaborator. He must trust us and must think this is important news for us. And every coach should do this kind of prevention training. And please note this name, the Get Set. This is a new app that we have developed together with the IOC. This app contains all the prevention videos for all the summer Olympic sports, and is free on App Store. It looks like this, and you can just click on the sport that you like and want to know something about, and you will find videos with training programs for shoulder, back, groin, hamstrings, knee, and ankle. And please use it and give it to all the coaches, the players, the physio, athletic trainers, physicians. All of you should use this app. And here you can get the video. So I think if you should remember one thing, Get Set is the app that you really should use a lot in your daily work. So with that, thank you very much.
Thank you, Grethe, and you can see the tremendous effort and resources that have been put into this. But like the Chinese proverb, a journey of 1,000 miles always begins with the first step. So I think in a contained environment like the University of Washington Athletic Department. It behoves us to really work with the teams and the athletic staff and even the administration to enforce this kind of workout as part of the preparation for sport. And now it gives me great pleasure to introduce Lars Engebretsen, who is the Chief of the International Olympic Committee Medical Affairs. It occupies 50% of his time, I suspect, which is at least 3 average working man's jobs anyway. So Lars spends a lot of time being involved in coordinating injury assessment, injury prevention, treatment education. And as part of this whole awareness in Norway, they were able to develop an ACL registry, and Lars is going to talk a little more about what they've learned about ACL injury and management from those resources. Thank you, Lars.
Thank you, Bruce, and thank you for coming this morning. I think that I will. First, I have to find my presentation. Actually, which is there. Yeah, that's good. So I'll try to put this into perspective, because I know that you guys are surgeons and you think that this stuff that we're doing here has nothing to do with surgery, which is completely wrong, and I'll talk about that first. So I have some disclosures, as you can see here. Nothing that will be involved in this talk. A little bit about Norway. 5 million people, same height as Anchorage actually, so it's pretty cold up there. But it looks like Seattle. This is the most famous Norwegian these days. Does anyone? I know that Professor Hansen knows, but anyone else know? This has become a national sport in Norway actually, which is very strange, because it's actually the world champion in chess. And chess has become a great game in Norway. People are watching it for hours on TV. It's very strange to me. But anyway, so he's 22 years old, world champion, and very good. This is, of course, our champions. These are the skiers who are winning gold medals and silver medals in the Olympics. And actually in the games in Sochi, Norway was the second, followed by, just following Russia. They beat us just the last weekend. And we actually beat the US. That was the first time in a very long time. So we had 26 medals in Sochi, which was pretty good. But we also have female high-level stars. This is Susan Peterson. She is the second best golfer in the world. And she lives in Florida, but she comes back to Norway now and then, and is absolutely a Norwegian. Now, that's the background. I've been in the ACL research business for 30 years. So I'm pretty old. And I'm as older than most of you actually, because you have never seen this before, probably. I know some of you have, but very few. Carol probably, and me, and some others. This is the arthroscope before you had the video cameras. That's when I started out in the 70s. And that was a very difficult time to do surgery, of course. And to teach resident was almost impossible. So in that time, in those years, I pursued ligament surgery in the knee and in the ankle and shoulder, but mostly in the knee. I developed, together with Rob LaPrade, a new technique for the posterolateral instabilities in the knees. We did a lot of cadaver work, clinical work, and publications for that. And then, after having done that, we went to the medial side and did the same thing there. First anatomy, then biomechanics, and then surgical procedures. This is the team doing that in Minnesota and in Norway. And actually, a lot of new stuff came out of that. And I'm just showing you this, not to brag about my accomplishments, that I've been doing this for a long time, but I'm doing this to show you that actually my background is in surgery. And I was trying very hard to enable me to do a good job on these athletes to get them back to sports. But then something happened to me that took my focus away from this a little bit. And that's when I met this girl. She was the captain of the national handball team. And they were going on to Sydney to win gold for Norway. She had an ACL injury, just like this. You'll see it right here. It's going to come up in slow motion pretty soon. And when you see that close up now, you'll see that you imagine it's not only the ACL. Of course, she was just going to have major injuries to her lateral compartment, cartilage, meniscus, and also a little bit to the ligaments in the medial compartment. It's painful, and it is bad for the knee. So, and this happened, and I got her 8 months before the Olympics, did the ACL on her, and she performed in the Olympics, but Norway didn't win. And after that, she had lots of problems. It's not her knee, but this is a while ago, and she does have heavy osteoarthritis, probably because of these injuries in the cartilage. And I sat down and thought, there's a piece over here, and quite a few is still under 15, and that is increasing. But over all these years, really the pattern has been the same. And the only reason we're saying that there is a difference between men and women, there are more women getting ACL. Well, that's correct, but only in this area here, in this age of 15 to 20. After 22, there is no significant difference. So that all is within the young females. And here you can see the age of the patients, and this is the a newer one. And again, you see this very clearly that the only difference is right up here in the 15 to 20-year-olds. Yeah, I don't think I'll do that. Then, we can look at things like, okay, what kind of fixation are we using? So we can, in every piece of paper, we'll put the fixations in, and we can look at if there's a lot of failures in one particular part of the new fixation device. There's a red flag coming up on my computer, and I can look at those patients and see if there's a pattern and if there is an increased revision rate in a new device, for example. That is an important way of doing it. We can look at meniscal treatments in newer meniscal devices the same way to see if any of them are malfunctioning. We can look at the hospitals. As you can see here, only 2-3 hospitals are doing more than 100 ACLs a year. I was just in China, in Beijing, and this is a hospital, did 2,000 ACLs a year in 100. So there's a huge difference, of course, here. And the question is, in Norway anyway, if you do less than 10 a year, you probably shouldn't do it. And it looks like that here in our data. So look at this. This is the cool score. So you go from 0 to 100, and basically it is sports and recreation and quality of life. These are the ones that discriminate well for ACL. So you can see revision there. This is a 2-year follow-up after surgery. You see that they are getting much better, and this is the 2-year follow-up in failures. Big difference. So cool score is a pretty good score for looking at the effect of surgery, of ACL surgery. How about timing? We looked at a lot of that. When should you do your ACL? What happens to you if you don't do your ACL? The main findings is that after the first year, each month you wait for an ACL, you increase your risk of having a cartilage injury by 1%. And if there is a meniscal tear, it doubles. How do we use this? Well, let me show you 2 examples. This is the one patient, 34 years old, previous surgery, meniscal tears and so forth. The baseline odds for cartilage lesion 1.3. If you wait 2 years, this surgery is going to increase by 20%. This is a way you can use these numbers. This is a younger boy, 17-year-old, just isolated ACL. And this was the other guy over here. The older guy has a 10 times increased odds for having a cartilage lesion if you wait 2 years. You can use these numbers to talk to the patient. How about the US? Well, if you look at Moon, for example, Moon is a ACL registry in the central part of the US, and we compare that to our registry in Norway. And actually, it is very similar. So here you see the numbers. And you can see the male, female, so forth, and age group is about the same. And if you look at the activities, the only difference is American football. But otherwise, we're pretty similar to the US. So we can use each other's numbers. And preoperative pulse is about the same in both of them. So that pulse is also good for the Americans. I think that is a good point, actually. I think our treatment of meniscal lesions, there are more sutures going on in the US compared to in Norway. Graft selection, there are more allografts here than in Norway, but otherwise it's pretty similar. Very little use of quadriceps here. And then we look at the difference between soccer players and other patients. So there are an enormous amount of things that you can get out of the registry, which is kind of can help you as a surgeon and as a hospital administrator. And this is the one that we compare with Kaiser. I just want to show you this because Kaiser is northwest or west in the US. And the same thing here. The results are very similar to the Norwegian registry. You know, you're using a little bit more of allografts in Kaiser, especially for revisions. And also a little bit more for young people, which probably is not good. In younger people, you have a 40% revision rate if you use allografts. So if you don't do that, I don't think it's wise. And I think I'm just going to show you this slide right here. No, sorry, this one right here. Because if you look at the revision rates here, young females double revision compared to males in the Norwegian registry. 10% revision rates in 2012. More in team handball, less in alpine skiing. And I think the major message here is that if you're doing young children, you have to make sure that you're getting a good graft and you get a good rehab and you work with a good physio. Yeah, I think that's the same thing, so I just have to show you that. But lastly, a few comments. What's the positive experience of having an ACL registry? Surgeon compliance is very good, 90%. That's because they're educated through the joint registries in Norway. In Denmark, they have a system, if you don't fill out the forms, you will not have reimbursement. That's a good system in a sense. That works very well. So far only in Denmark and Finland here. All the surgeons get at hospitals get the annual reports and individualized statistics. So I can ask for my statistics in the registry, but I cannot ask for your statistics. I can compare my clinic to the national data, but I cannot compare my clinic to another clinic next door. So we get a lot of epidemiological data. Industry is very keen on getting implant data. So far we have not had any support from industry, and we probably want to stay out of that. We can monitor trends and developments. The shortcomings, endpoints and compliance, you know, there are people out there who needs a revision who are not revised, and that's why we're using a KUS score. The KUS may not be the greatest thing. Maybe Julie can tell us something else. Maybe we should use another score than KUS. We should have a control group which do not have surgery. In Norway, 4,000 ACLs a year, 2,000 have surgery. Well, they are the ones that are put into registry. The ones that are treated non-surgically are not in here, and that's a very bad shortcoming at this point. Limitation, that's what I'm talking about. And I think that revision is a suboptimal endpoint. Yes, we are getting to poor implants now. We're just reporting in a few weeks the results of the different implants on the femoral side, so we are getting to that. Is there a difference between Scandinavia and the rest of the world? Not between Scandinavia and US anyway. That is pretty solid data. What we cannot demonstrate, however, is we don't have, close follow-ups. We don't know the amount of OA in these patients. And we don't have any data on things like this. And we don't have close follow-up. We only see the patients when they leave the hospital. They fill out their 2-year, 5-year, and 10-year hospital. So there are some limitations here. And I know it's going to be hard to do that in the US, but I think in small states or in groups, you can do it, and it's been shown by Kaiser and by Moon that it is possible to do. I think that the Scandinavian registries are giving us good data, and I think it's good. Somebody told me yesterday we cannot do this in India because there's too much difference in medicine. Secondly, they will not fill it out, the compliance will not be good, and so forth. In my opinion, it's possible to do it. The strange thing is, about that. You can talk to me about that afterwards. It tends to be more expensive in the US. So I hope I've been able to show you, first of all, that, I'm a surgeon. That's what I do. But to fulfill my obligation to my patients, I have to have some knowledge. That's why I'm working. I think the preventative thing is a long-term task for us. It's going to take us time to get through this whole summit. So I think it's going to be very important, and it will actually probably develop into the source of knowledge on which graphs to use, which graphs to use. Thank you for listening to us.
So Lars and Grethe, you've put a lot of time into helping us with this. So we have a small present for each of you. I'm not sure whether that's the boys or the girls better, but
Thank you.
I'm sure you can sort that out. It's the official custom thing hoodie for the football team. So you're now officially custom. I expect you to wear purple on every opportunity. Again, I'd like to thank you for all the time and effort in the education. Hopefully these are small things that things we can change and do for the University of Washington to allow us to start creating some very good understood what they can do in the way. So thank you very much.
Thank you. Very good. Yeah, you got your